Ohio House Bill 454, also known as the Save Adolescents from Experimentation or SAFE Act, Families, Aging, and Human Services Committee. Second hearing, May 19, 2022. Testimony by Dr. Daniel Weiss, proponent.
I'll now call on Dr. Daniel Weiss. Welcome to committee.
Thank you. Chair Manchester, Vice Chair Cutrona, Ranking Member Denson, and members of the House Families, Aging, and Human Services Committee. Thank you for this opportunity. I'm here to support the Save Adolescents from Experimentation Act, the SAFE Act. My testimony is strictly my own. It does not represent any healthcare organization in the state of Ohio. I'm a board-certified internist and endocrinologist. I have practiced in Northern Ohio since 1986. I'm also a certified physician investigator, and I've been involved as the principal investigator for over 100 clinical trials involving both adults and children. Physicians have three fundamental responsibilities. We must first use our expertise to diagnose, and second, to care for our patients, and thirdly, we must be certain that our patients understand and fully consent. Diagnosis of a medical condition is not delegated to the patient because it requires expert medical evaluation. Physicians who see a child with distress, possibly related to gender, should not agree to the child's diagnosis any more than they would agree with a child who thinks he or she has diabetes or cancer. Once the physician is confident in the diagnosis, he or she can weigh the best care or treatment for that patient. And a cardinal principle is, first, do no harm. Finally, physicians must obtain informed consent, especially for any experimental intervention. Ethical practice prohibits children from providing consent. Children cannot fully comprehend risk versus benefits, and at most can provide assent to a parental decision. Children must obtain consent from their legal guardian or parent for any medical treatment or surgery. Treatment for gender dysphoria should not be an exception to this requirement. I stopped accepting new patients with gender dysphoria because I had discovered that most had stories of traumatic childhoods and comorbid depression. Most had inadequate psychological evaluation before they were cleared for treatment. Hormonal treatment did not resolve those underlying psychological issues. Parents are often told that if they fail to go along with hormonal interventions for their child with gender dysphoria, he or she will commit suicide. However, the best evidence proves this to be completely false. A long-term study of adults in Sweden, this is the best study, found that despite cross-sex hormones and surgical reassignment surgery, there was a 19-fold higher suicide rate and a 3-fold higher overall mortality in transgender persons as compared to the control population. The only study on hormonal treatment of gender dysphoria in minors is a so-called Dutch study. That study found no improvement, none, in depression, anxiety, or anger after treatment in a small group of 55 children. To summarize, there are no studies that demonstrate clear benefit with hormonal or surgical treatment for children with gender dysphoria. And there is increasing evidence of harm with puberty blockers or cross-sex hormones, damaging bone health, cardiovascular health, and fertility. And there's an increased risk of cancer, it appears. A paper published just this year in the Endocrine Society's key journal described the evidence on hormonal interventions for gender-diverse adolescents as sparse, of low quality, and with potentially irreversible side effects. And GnRH analogs, so-called puberty blockers, are not FDA approved for treating gender dysphoria. All these facts mean that puberty blockers and cross-sex hormones are experimental interventions for gender dysphoria. The SAFE Act aims to protect children from these experimental therapies. There are an increasing number of people who were given hormonal or surgical treatment for gender dysphoria who later regret such treatment. I estimate that 75% of my adult patients fail to persist in their treatment with me. Recently, I saw a man who regretted having his testes removed within 1 year of that surgery. I strongly support the SAFE Act. The SAFE Act is an act of harm reduction for children, and I provided a long list of references. This is actually quite a selected and short list of what's available, but some key references in my testimony. Thank you.
Thank you so much for your testimony today. And before we get into questions, I just want to remind members our goal with our witnesses is to ask questions and not make statements. Representative Troy.
Thank you, Madam Chair. Thank you, Dr. Weiss. The last thing I anticipated seeing appearing in committee this morning is my personal diabetes doctor from Lake County, and I hope you weren't here when my aide snuck in that banana nut muffin that I ate. And once I saw you out there, I have not consumed the rest of this. So anyways, my question is I understand, your opinion, and you've indicated about do no harm. How do you explain the fact that there is a divergence of opinions within the medical community on this? That the American Pediatric Society indicates that they strongly support this type of therapy, and then you from your particular side of the profession, the other. I mean, what is this something where the jury's still out? I mean, are we in a position where maybe we should not be preventing? I mean, maybe we shouldn't be permitting this, but we also shouldn't be preventing it. I guess what's your feeling on that, Doctor?
Through the chair to the representative, thank you for that important question. And I think that challenges us and disturbs a lot of people, because especially if they don't have medical expertise and they're not familiar with the medical literature. So I believe that the society guidelines are biased and do not represent their members. Many members are passive, don't get involved in the decisions or the guidelines that are promoted by those societies. And remember, the guidelines are not the same as standards of care. Standards of care are based upon rigorous evidence. A lot of guidelines, and someone mentioned WPATH and what the AMA might say, those don't reflect dissenting views, and dissenting views are suppressed or ignored because of activists and by physicians who profit from transgender clinics. And that must be kept in mind. The guidelines are based, again, on flimsy data, those guidelines, and as I stated in my testimony, and they're driven by ideology and the profit motive, influenced by activists who are very involved in this. It's very important for them, and they've been working on this for decades, and by physicians who benefit from a profit standpoint. I'm one of the few endocrinologists who has fairly extensive clinical experience treating gender dysphoria, although in adults. And in my experience, these treatments do not help the emotional suffering of these patients.
Follow-up? Representative Liston?
Thank you, Chairwoman. Lots of questions. You mentioned clearly that you work with adults, and I guess I have a couple questions on your conclusions regarding the evidence. I'll build on Rep Troy's question a little bit about where the medical community falls on this, because I do not see any lingering controversy regarding gender-affirming care, which is a broad context and a broad term, but this bill specifically prevents. So I see no organization, society, group of physicians that work with this patient group, none that would say that this bill is a good thing, and that are not very specifically advocacy groups. And so I'll name them again, and that includes your endocrine society, your professional organization that you've already quoted, states that gender-affirming care is the standard of care for trans individuals. And so is it your contention then that your reading of the literature, again, which is selected, as you would agree, is more accurate and comprehensive and less biased than all of the other medical organizations that have come out in support of gender-affirming care?
Okay. Through the chair to the representative. So I think you're not a physician, with all due respect.
I am a physician.
You are, okay.
I'm an internal medicine and pediatrics and
Wonderful.
a pediatrician for 20 years.
So if you and most physicians are not familiar with the literature, and most of these societies are heavily influenced and swayed by activists and by physicians who run transgender clinics, who have the profit motive, and they're followed. They're not involved. The societies don't have members actively involved in decision making. They're often passive, and they don't know the literature. So there are medical organizations, in fact, that would heavily support this bill. And this is not, I think we have to watch the language. If a patient comes into the office, let me give you an example. A patient comes into the office and says she's underweight. And she says, I'm much too fat. She's underweight. You want to then give her weight-affirming care. So you give her a weight loss drug? No, you don't give her a weight loss drug. She's a minor now. She's 16. She says, I'm really much too fat. In fact, she has anorexia nervosa. As a physician, you know what that means. She's got amenorrhea. She's underweight. We don't give her weight-affirming care. It's nonsense. It's basically the manipulation of language to then relinquish the physician's role in the management of the patient. They basically, those physicians say, I'm not going to diagnose a patient. We're going to let the patient diagnose themselves. They come in, I don't like my gender. I'm going to change. I want to have gender-affirming care. Okay, fine, go ahead and give it. It's irresponsible. And there are many physicians who believe that it's irresponsible. But societies have been co-opted by these activists, and that's my position. And I think the scientific literature, careful reading of it, not reading of it, because most of the literature is actually garbage. There's very few randomized controlled trials. If you really look at this, the scientific literature does not support this kind of interventions, especially for minors. And there's clear harm. There's emerging evidence of harm, infertility, bone loss, and even those people who support this so-called affirming care, they agree we have to look at fertility preservation. Oh, yeah, maybe after we remove someone's testes and make their ovaries non-functional, we have to think about, maybe that person wants to give birth later on. It's really, frankly, I think it's insane to just delegate care to the child. It's irresponsible, and it's dangerous, and I think the state has a responsibility in helping parents out in this, because there's a lot of confusion, and there's even confusion amongst physicians who don't have a knowledge with the scientific literature.
Follow up?
Sure. So to sort of bring that together, what I'm hearing is that, yes, your conclusion is that your reading of the literature is more accurate than the rest of the medical bodies, and that you are less biased than all of the medical professions that have otherwise come out in support of gender-affirming care, and that all of the gender-affirming clinics, so for example, the Thrive program at Nationwide Children's or the Guide program at Cleveland Clinic, that they are simply working against their patients for profit and do not have accurate information in their treatments.
I think they're not carefully reading the literature. That's right. They're doing it experimentally, and even people who are strong proponents of this admit there's large knowledge gaps, and we really don't know a lot. So it remains experimental. There's a lot of uncertainty in this, and yes, I would agree with that they're not doing what's best for children, certainly, and children certainly can't make these decisions.
And you conclude that as a non-pediatrician.
through the chair to the representative, I don't need to be a pediatrician to be able to know that this care is harmful to children.
Representative Edwards.
Thank you, Chairwoman. Thank you, Doctor, for joining us today. You bring up the Sweden study, I believe, as well, and say it's the best study out there, I believe was your words. Is there one common denominator that these other studies are doing that's wrong, or they're cherry-picking information to come out with a result they might want? I'm just curious of what they're doing wrong, or is it all different?
Through the chair to the representative, there are no control groups in any of these studies. So the gene study, which I referenced, just follows it's not really such a large group. It's 300 children who are followed over time, and it is clear that children who have gender dysphoria may be at increased likelihood of having anxiety and depression, social anxiety. There's a lot of influence from the social media now, and that's why we're seeing more and more children with the hope that by treatment with hormones and puberty blockers, they can mitigate their anxiety and depression. But if one utilizes the principle of first do no harm, it means that keeping in mind that 85% of those children that gender distress will resolve over time. So don't use drugs to intervene and potentially cause increases in all these adverse outcomes. Give them time, allow them psychotherapy if necessary. Children who've been a girl who's been sexually abused, if you just think, well, I'm going to do gender affirming care, she might want, because of her sexual abuse, now want to be a boy. But if you don't address that sexual abuse with appropriate, perhaps long-term psychotherapy, you're going to be giving her cross-sex hormones for a psychological problem that's not the answer. And that's why we're seeing more and more children and adults come out having regrets. Their websites, their YouTube postings of many, many children and adults now who have had either hormonal therapy or surgical therapy, and they express great regret that they were misinformed, mistreated by physicians with approaches that really don't address their underlying cause for their distress.
Representative Ginter.
Thank you, Chair. Thank you, Doctor. I've been in another committee, but I caught just enough of your testimony and the question and answer here to ask you a question. First of all, do you believe, in regards to the current medical education that is established in the United States, let's stay specifically here, that there is a leaning towards, in regards to gender dysphoria, is there a leaning towards behavioral therapy or hormonal surgical treatment in regards to what our students are being taught?
Through the chair to the representative, thank you for that question. I think clearly there's evidence of the activist influence and the bias towards interventions which are potentially harmful and not psychotherapy, not really addressing more the psychological aspects for that individual who's suffering, but maybe just using drugs and potentially surgery. Yeah,
Follow up?
Yes, thank you, Chair. So having said that, would you say, and this is purely a subjective opinion, but would you say then that would lead to the possibility that there's a large group of physicians or potentially large group of physicians that feel intimidated to give their own feelings in regards to this particular subject and are silent because of that?
Through the chair to the representative, thank you. I think most endocrinologists don't treat because they're really uncomfortable, and I think appropriately uncomfortable in treating with hormones. And I think the vast majority of physicians are passive in the face of activist physicians who often run editorial boards, decide on what's published, often really poor science, and who run transgender clinics.
Follow up?
One more. Thank you, Chair. So I guess my question would be this. I'm looking at not only the scientific evidence, which we must look at, but I'm also looking at the philosophical approach in this particular subject. And I believe that that goes very deep. Does it go back to the definition of whether gender is biologically determined or socially constructed?
Through the chair to the representative. Thank you. I think it's a complex question, and I think that is a subject that I think many physicians are uncomfortable at addressing, and perhaps that's part of the reason they stay away from their viewpoint, expressing their views. So, for example, the Endocrine Society will come out when they'll have this is our set of guidelines where we'd like to have some commentary. Well, most people don't comment. And I know of physicians who have commented, and basically their views are dismissed and suppressed because they don't have power. You're in a minority view, and we don't care, even if you might criticize the science. This is how we're going to go, and these are the guidelines we're writing. So it's a power play, and there's lots of forces there, and there's money, and there's activism, and there's people who are passive. They're either afraid or they feel they can't do anything, and it takes a lot of time to put that effort in. There are people who can become violent when in response to those who express views that challenge this.
Thank you, Chair.
Representative Smith?
Thank you, Madam Chair. Through the chair to the witness, trying to get a sense of your own firsthand experience with all of these kinds of treatments. So you don't treat children. We're talking about
no,
kids.
I'm an adult endocrinologist. The youngest person I treated was 18.
So you have not treated anyone under 18, sir? I'm
Correct.
Sorry, follow up, please. Just want to make sure I'm understanding. Okay, so that's good reference. So you have zero experience dealing with the population that this bill addresses. Thank you.
Representative Liston?
Thank you, Chairwoman. Sorry, this is one quick question that's more of a follow-up, and then I'm going to get to my secondary question, if that's okay. I'm hearing a lot of physicians are activists. They're being taught to be activists, but they're also being silenced. And then we're talking about medical education. Are you involved in medical education? We've asked about what your opinion is on how students are educated. Are you a medical educator?
Through the chair to the representative. Yes, I am involved in education. And I was talking about activists who are primarily non-physicians. There are some physician activists. Some of them run transgender clinics. But then there are physicians who are involved in treating patients. But the majority of physicians aren't treating transgender. They're not treating gender dysphoria. They're not treating them. The majority are not. They're not comfortable doing that, as I said, understandably so. And they're passive in the face of guidelines that are written often by the influence of activists, but written by physicians who often run transgender clinics.
Follow up? Sure. So that brings me to sort of my question, because I feel like your understanding of the gender-affirming care in youth may be incomplete, right? Because I think all of us would agree, and everyone at a gender clinic, at the Guide Clinic or the Thrive Clinic, would talk about the intense support and therapy that kids get, that this bill would shut down. And I guess I would ask, have you had any experience or been to any of these clinics and talked with any of these the individuals that do provide the care to inform your current understanding of pediatric therapy of transgender youth?
Through the chair to the representative. So as a previous witness, Matt Sharp, had referred, there are countries that have been doing this gender-affirming, so-called gender-affirming care for years before we were. and they've decided, based upon the scientific literature, that hormonal treatment, puberty blockers, cross-sex hormones, eventually sex reassignment surgery, is not the best way to go. That is their conclusion based upon that. Their long-term experience treating children, and they recommend now, this is now, for example, Finland and Sweden, not doing this and offering psychotherapy first. The data would suggest that those children who involved in these centers, centers for where gender-affirming care, I think it's a really terrible term because it's destructive and it's misuse of language. Just as an example, I was a weight-affirming care, okay? So in these clinics, we know that once they start, the vast majority of the children continue and they do not reverse, they do not desist, because they're kind of in a hothouse and they don't want to probably disappoint their providers, and they're being seen so regularly. And so they're forced down this one-way street most of the time, despite the claim that it's potentially reversible, they can drop out. So I'm not convinced that they really get much therapy. And the question is, how well would they do with psychotherapy alone without those harmful medical interventions? That's the key question. They don't get that. They're not getting that in these gender clinics. They're getting therapy plus hormonal treatment plus potentially dangerous therapy.
So thank you, Chair, for follow-up. I hear you referencing other countries. I hear you referencing what you believe happens, but I'm trying to get an understanding of what you're basing that belief on in Ohio, right? There are very specific specialized clinics that provide this care. You know, insurance isn't covering surgeries for gender transitioning for kids. So people aren't, I would say that that's not really happening. We're talking about these gender affirming clinics in our state and what is actually happening at those clinics, which I think you have how about your perception of that is very different than mine. And those that I have spoken with and met with that actually work in those settings. So where are you getting your perception of what happens at the clinics in Ohio?
Through the chair, to the representative. So I think it's immaterial whether I've visited the clinics or I know or I've taken care of patients in those clinics, because the key thing is they're in the clinics and they're not just getting therapy, psychotherapy. They're not just getting that. They don't have to go to the clinics just for that. Once they get into the clinics, they're getting it. They're getting in the clinics and they might have concomitant psychotherapy along with hormonal treatment. The question is that how harmful is that care there, and would they be better at not going to that clinic, seeing a therapist in the community who can feel comfortable supporting them closer to home without the pressure to have hormones and puberty blockers introduced on top of therapy, because the literature is not convincing. It is absolutely not convincing that they do any better with those hormonal therapies than they would with therapy alone, or perhaps even being left alone so that their dysphoric symptoms may resolve over time. And that's the key point.
I would say that when we're discussing the harms and benefits, it really is important to know what actually happens in the care. And that's a crucial point of to me, when we look at this. To know what actually occurs, because I think you're misinformed.
Through the chair, to the representative, there are no data at all published that show that puberty blockers or hormonal therapy in whatever venue is helpful on top of psychotherapy.
Representative Cutrona?
Thank you. Through the chair, to the physician. So based upon your skill, training, and experience as a medical doctor, as a medical physician, what I'm gathering is that this treatment with hormones is more harmful than good for these children, given those particular circumstances. Am I understanding that?
Through the chair to the representative, yes, that's what the science shows.
Follow up?
One follow-up. And so, through the chair to the physician, so then basically what I'm hearing is this is very much so more of a mental health issue then. Is that accurate? I mean, that would probably be a better step then perhaps to engage in that activity than using these hormones and using drugs that are not FDA approved for these particular situations. Is that
Through the
correct?
chair to the representative, yeah, yes, sir. The science and the principle of first do no harm would support supportive ethical psychotherapy to help the child relieve the emotional suffering, deal with their anxiety, deal with their depression, and not throw in drugs that do not have scientific support and are not FDA approved.
Are there any additional questions for the witness? Representative Click?
Thank you, Chair. Through the chair to the physician. First of all, welcome to Ohio.
Thank you. I'm in Northern Ohio.
Oh, you are from Ohio.
I've been
Thank
here
you.
since 1986.
Well, thank you, sir. I appreciate you. I am looking at the website for Trans Ohio, and I'm looking at the resources and the providers. Did you know that you're listed there?
Through the chair to the representative, yes, I was listed there for about 10 years and was the key resource for the LGBT community in Northern Ohio.
So should they through the chair, should they update their website?
They probably should.
Okay. So also through the chair
Follow-up?
to the witness, so that means that you don't hate LGBTQ people because you've provided services before. Is that correct, sir?
That's correct.
And
Follow-up?
follow-up? Yes. So you mentioned some things out here, and Representative Ginter touched on one of my questions as well about, physicians. Do you believe that physicians are afraid to speak up? Are there consequences for you socially and in the community and in society when you speak up and say, I don't agree with endocrine society. I don't agree with this type of care. I think it's inappropriate and it does harm. Are there consequences? Because I know I've talked to several physicians who agree with us, but they are intimidated from speaking up.
Through the chair to the representative, I would agree with that. And in my when I teach endocrinology fellows or residents in my practice, and I will see some of the patients I've continue to see who have transitioned. Some have had surgical reassignment. I continue to follow them under my care, but I'm not taking new patients. They have asked, oh, gee, I don't really feel comfortable seeing those patients and doing that care with patients in the future. Do I have to provide hormonal therapy for people with gender dysphoria when I go out into endocrine practice? I said, well, that's your choice. You don't have to do that. A lot of them are uncomfortable with it and certainly would be afraid to express their views that might dissent from those of the Endocrine Society or other organizations. And keep in mind, the AMA, regardless of their views, it has, I think 12% of doctors are members of the AMA. It does not represent most doctors in this country.
Follow up?
Yes, thank you. Through the chair. Do you know how long we have been providing this care for minors? And I know you work with adults, and maybe Dr. Van Maal could answer this if you can't. But as my understanding, and approximately 10 years ago, we only had 6 clinics throughout the United States doing this, and now we've got 7 in Ohio. So do you have any idea how long we've actually been performing this hormone therapy on young people for gender transition?
Through the chair to the representative, no. I know in the UK they've been doing the Tavistock Clinic for decades. And when I was on the LGBTQ site, I was one of just 2 endocrinologists in Northern Ohio providing that care to adults. This was to adults. And now now the Cleveland Clinic wasn't doing it then. Now they have their clinic. And so there's a lot of money in it. And
Okay.
Are there any additional questions for the witness?
Yeah, just
Representative Click?
some follow up. Yes. So, because so if they've not been providing it for that long, that might be why. I'm guessing. Do you think this is why that maybe the Dutch protocols and in Sweden, they're farther ahead of us in the research because they've been doing it longer than us, and we're trailing, are we trailing 10, 15, 20 years behind them?
Through the chair to the representative, I would estimate that. Don't hold me on that. But yes, certainly they've been doing it probably for 15, 20 years longer. And so they have a lot more experience with many more children and adults than we have in the United States. And I think we can learn from those other countries. If they say, hey, hold off on this, this is not the best way to go, let's do psychotherapy first, why not learn from that experience?
Are there any additional questions? Representative Click?
Yes, thank you, Chair. Through the chair to the physician. I do understand that in my experience, my reading, my study, and people I've talked to, is that affirmation is the standard of care. And so is that true? Is that your understanding as well, is that when a child presents and says, if it's a female, says, I'm a boy, that the standard of care is to agree with them that I'm a boy, or if it's a boy, to agree with them that they are a girl? And if you do anything else, is that considered reparative therapy or conversion therapy? I'd like to have your input on that, sir.
Yeah. So through the chair to the representative, I would be just careful in using terms standard of care. Standard of care is like this is the best evidence shows. So the usual guideline is to, yes, delegate your decision to the child in this case, but in no other medical context. Do you delegate to the child and say, okay, yeah, this is the way to go. If the child says, I want to be the opposite sex, then that's what you should do. That's what guidelines from many of these organizations would have you follow.
One additional follow-up?
Thank you, Chair. So I don't know, are you familiar with, through the chair to the physician, I don't know if you're familiar with Dr. Ken Zucker, and he was trying to provide, as my understanding, is psychotherapy care and the watchful waiting, and I believe some false accusations were made against him. Is that correct, sir?
Through the chair to the representative, anyone who challenges the prevailing guideline, I think, has a real difficult time getting their work published. Many opposing views come out as letters to the editor because they can't get a formal publication because the editorial boards are controlled by people who promote these guidelines. But Ken Zucker, I think, is the editor of Archives of Sexual Behavior, and he's a strong proponent of therapy, watchful waiting, and not harmful medical interventions like drugs and puberty blockers.
Are there any additional questions? Representative Click?
I'll keep it
One
short.
final?
Yes, one final.
In the interest
My
of our other witnesses and out of respect, thank you for your time.
So, and is it your understanding that he is also the chairman of the DSM committee and probably the leading foremost expert on this care, and yet politics still got to him? Is that true?
Through the chair to the representative, yes, that's my understanding.
Thank you very much for your time today,
Thank you.
Doctor. Have a wonderful day.